This is the second in a series of monthly webinars provided free by Healthy Heart Charity, the Cardiovascular Research Trust. Today we should be discussing links between cardiovascular disease, cardiovascular risk, and COVID-19. We have an international panel of contributors from the UK, Hong Kong, India, and the Middle East. The virus which causes this serious infection is the SARS-CoV-2. It's a coronavirus. The SARS coronavirus 1 emerged in 2002, causing a serious respiratory illness with high mortality. A serious, similar Middle Eastern respiratory syndrome emerged in 2012. People who got the SARS-CoV-2 version, all three of these coronavirus respiratory syndromes arose from viruses with animal reservoirs. Those with comorbidities more likely to be infected include those with hypertension, coronary heart disease, diabetes mellitus, and obesity, and not just the elderly. Being older is not good news, but there have been reports of young, overweight people from the USA, from Italy, from the Netherlands who are also seriously affected. But looking at a little bit more detail, it's not just that these people are more likely to be infected, they're more likely to be seriously ill, to end up in intensive care, or to die. And for example, in some early reports from China, published in JAMA, around 60% had hypertension, 25% had heart disease, almost half had had a previous arrhythmia. And if we look at the USA, a similar sort of experience, a lot more hypertension, although this tells you something about the US population. You're seeing there 45% would be expected of hypertension in that population of interest, but that goes up to almost 60% in those affected with the disease, obesity, diabetes, So 3 times more likely to be a diabetic with the disease than the general population. We look at the mortality. The early reports from China were that those without any comorbidity, less than 1% would die, whereas the people with cardiovascular disease, almost 1 in 10 were dying. Diabetes, 1 in 14, hypertension, 1 in 16. And as I mentioned earlier, we know that people that were getting infected young are affected. It's not a question just of older people who would otherwise have died. For example, in some Italian and Dutch cohorts, roughly 1 in 8 of all the patients were young, overweight patients, and 1 in 25 of those who were critically ill. If you look at a bit more recent data, this is again from China, published in The Lancet recently, we can see that hypertension appears to be a striking link to being more likely to have the disease, with an odds ratio of roughly 3. That's to say, if you've got high blood pressure, 3 times more likely to die than those who don't have high blood pressure. Similarly, for cardiovascular disease, roughly 5 times the mortality than those without cardiovascular disease. I should say there are some concerns about confounding. That's to say, in many of these studies, there are 2 problems. They've not always been very good at capturing the important data, knowing who had all these risk factors. And secondly, there's a question of what about adjusting for age? So there may be other aspects of aging which are also putting you at risk, whether it's to do with immune response or ability to fight infection in other ways. An important question which came up early on throughout the world has been the fact that people from ethnic minority groups appear to be more at risk. For example, in the UK, around 1 in 3 of all patients admitted to ICU, intensive care unit, due to the virus came from an ethnic minority, as opposed to around 1 in 10 of the population. So 3 times more likely. And similar message in the USA. Now, we're not sure why this should be, but it's the possible explanations include a higher prevalence of cardiovascular risk factors such as high blood pressure, diabetes, or insulin resistance, and just being overweight. But there may be other cultural factors involved. And in addition to that, there are some further differences. Vitamin D deficiency, particularly in South Asian groups, is an issue. and that predisposes to infection. But there may also be increased inflammatory burden for other reasons. Now, let's just look a little bit more in terms of what we know about the mechanism. What's very interesting is that it's now known that for the first SARS virus, the one from 2002, and the more recent MERS, and now COVID-19, the virus responsible is able to home in onto target cells through a particular attachment to an enzyme which is present on cells. And what's also interesting is that there's a cofactor protein, transmembrane protein, which works in two ways. It activates the ACE2 by cleaving off an inactivating part of the protein to make it easier for the virus to stick on, but also the same protein is able to attack the virus itself and make it more active. One of the glycoprotein spikes is activated to be more easily able to enter the cells. So why should that be a problem? Well, this particular protein is a docking protein which is found very widely, particularly on vascular endothelial cells. In the heart, the pericytes, the small cells that circle small blood vessels, are also particularly rich in this protein, therefore a particular target. And this particular protein is also switched on in a number of risk factors, but also more likely to be present in larger number in people on common treatments for heart disease, ACE inhibitors, and other renal system blockers used widely for hypertension, for heart disease, as well as for renal protection in diabetes. Now, if we look at what this may mean for future targeting, we know that the vaccines which are being developed, it is hoped that they will be able to generate immune response, to generate proteins, antibodies, which will bind to inactivate the virus. But it could also be some beneficial target, could be against the ACE2. Now, ACE2 is important for, as an enzyme for the renal system, but by inactivating this enzyme, it could be you might help reduce the ability of the virus to enter cells. That's a question for future pharmaceutical research. Now, what sort of damage happens in patients linked to heart disease generally? Well, myocardial injury to muscle in the heart, is found in around a quarter of critical cases. And in blood tests, what you can see is evidence of increased inflammatory cytokines like interleukin-6, increased D-dimer indicating a coagulation system activation, as well as ferritin being elevated. And there seem to be two patterns: an acute injury, which can either be the virus directly damaging the heart muscle cells, or indirectly causing problems through endothelial damage, causing poor blood flow and damaging muscle. But there also appears to be an injury which emerges over 1 to 2 weeks, which is likely to be immune in origin, with patients apparently initially being stable or recovering and then becoming much worse after the second week or so. So putting that together, what we have is the ACE target protein with the virus coming into cells, possibility of direct viral damage inside muscle, causing damage, but also activation of the patient's immune response. And if that's overactive, the idea is this should be targeting the virus, but also it could be damaging the patient's own body. And these multiple inflammatory factors can target muscle as well as damage arteries. And there's evidence that people who've got a stable plaque with coronary disease may make this unstable and develop an acute coronary syndrome. And together, this can lead to heart failure or sudden death arrhythmias. If you put that together, we have risk factors and we have various cardiovascular syndromes. But I've got on here, you can see venous thromboembolism. Now, it's known that many infections can stimulate the coagulation response in a number of ways. And it appears that the SARS coronavirus 2 is more likely to do so than in other settings. Now, these procoagulant effects can cause unexpectedly severe lung damage. People who shouldn't be as unwell as they seem from the pure physical signs and imaging may be worse because of having pulmonary embolism. That, of course, will make them hypoxic and more prone to cardiac ischemia. Just to give you an example, of what you can see here is on the top is the ground glass change from the pneumonitis from the virus, and below in the arrows you can see filling defects in the pulmonary veins, indicating serious pulmonary emboli. And that of course, then leads on to recommendations now that patients should, as any sick patient in hospital, should be effectively anticoagulated with heparin equivalent. There's also the question of what about targeting the cytokine response, which may be exacerbating the procoagulant effects of the virus. Now, thrombin is really important in clot formation, but also it's got inflammatory effects. And it may be that blocking these particular receptors, the proteinase activated receptors, PAR receptors, could help to reduce the severity of viral attack. And so there is experimental work looking at these PAR inhibitors to see whether they could be of interest. And that may reduce the inflammatory response. The catch, of course, is that inflammatory response is a good idea. And it turns out that in some settings, if you use these inhibitors in the wrong way, you can actually have the experimental animals iller, because you need some of this response to be able to initiate dealing with the virus. So moving on to another category, why else might people who have the virus be at risk of cardiovascular problems? Well, the reason includes the drugs they're being given. There have been many empirical treatments around the world with antivirals, with anti-inflammatories and so on. And the catch, of course, is that any good drug is a powerful weapon and can have expected, unexpected harmful effects. So really, we should be making sure that any patients with the disease are given treatment within trials rather than empirical treatment. So for example, the antimalarials, chloroquine, hydroxychloroquine, which are used in this setting because they're anti-inflammatory, they may cause serious cardiac toxicity, serious arrhythmias, as may some antivirals. And so we must make sure that patients are being monitored and these drugs are used appropriately within the trial setting or under close regulation if they are approved. What about other reasons for increased cardiovascular disease? Interestingly, there are cardiovascular implications of social distancing, not the much talked about mental illness element directly, although that is an issue. But it turns out even people who do not feel lonely, do not have any obvious first-rank symptoms of depression, are more likely to be developing cardiovascular disease. And particularly those with a cardiovascular background. For example, the UK Biobank, a huge collection of patients, over 500,000, in a recent report last year in Heart, noted that people with a background of heart disease had a 25% increase in risk of serious disease if they were socially isolated, and for those with previous stroke, a 30% excess risk of a recurrence. Secondly, as we know, we'll hear a bit more about one of our contributors, with not being able to be seen by the usual community physician or hospital, then risk factors may not be identified in the first place or may be poorly managed. There's also the question of people at home not looking after themselves, being malnourished, dehydrated. If you're dry, you're more prone to vascular increased viscosity and heart attack and stroke. And the other thing is that although adherence generally is a problem with not taking enough medicine that should be being taken, certainly people can be too well behaved, they're not feeling well, not eating and drinking, they keep going with their blood pressure tablets and they become hypotensive. And that's another concern. We shall now hear from our other contributors. First, Mr. Iyengar from Southport Hospital in the UK will discuss using telemedicine to reduce cardiovascular risk in orthopedic patients.
It was on remote strategies in trauma and orthopedic patients. And what we have found is as COVID necessitates reduction of face-to-face consultation, we had to find a way we could provide continuity of care during this last 3 months. And traditionally, we did have some amount of tele or video consultation, but we paced it up quite rapidly in setting up specific rooms. We got the NHS Attend Anywhere platform. We got our cameras, rooms associated, and we have tried to get down our ratio of telephone or video consultation to a higher level than what it was prior to the pandemic. And patients do seem to like them as well, in that it reduces their travel. They are able to ask more questions. They seem reassured with this. So I think overall, as we see with the number of publications and studies coming along, I feel tele and video consultation is here to stay. And we, as a healthcare provider, should invest more in getting this technology set up at our NHS, and also make sure that the patients are comfortable with it, because there may be elderly patients who may not be well versed with the technology. So we should help them as well, and have the 4G or 5G network which allows these consultations to occur. However, the key thing I feel is we should have enough virtual rooms. I feel this is a good tool, especially for people who are follow-up patients. Sometimes acute injuries do need to be seen. However, if you have follow-up patients, this can be well managed with telephone or a video consultation, whichever is possible in the setup you have. And that I would like to emphasize and probably carry it forward in multiple other specialities.
People who are less mobile for orthopedic reasons or any reason really may develop a DVT or pulmonary embolus and may not realize what's going on. And you mentioned that as one of the things you can check with the telemedicine. I just wonder whether you have a pro forma sheet, how you do the checking, and also whether you've picked up patients in your clinic so far who've got warning signs of this, so you can help them.
Yes, interestingly, after your invite, I did look into, and I have made a pro forma which I am going to institute in my hospital. I made a A4 size virtual assessment of a patient who may be at a risk. So obviously the trick here is how can you assess a patient remotely for VTE? So I've templated the same clinical examination tools, that is look, feel and move, and put that in my pro forma. The patient saying, yes, I have pain. He or she can point out which part of the leg is painful. You can also, from your video camera, see if the leg is swollen. From the history, you have asked the background of comorbidities and any risk factors the patient already has. So from that clinical history and video examination, I can come to a suspect this patient may have a high risk of VTE. So then I would try to organize whether the patient needs to come in to have a D-dimer or have an ultrasound organized, or I can with my practice nurse to whether he or she really needs to get prophylactically anticoagulated while she is waiting for an ultrasound. So this is going to be a good tool where I can risk stratify a patient who, say, for example, is in a high group or in someone who I can monitor from a weekly televideo consultation, especially in this situation where patient may be shielding.
Our next contributor is Dr. Prashanth Kulkarni, consultant cardiologist in Hyderabad, India, who will discuss his recent communication in the Postgraduate Medical Journal.
Age and comorbidities like obesity, COPD, diabetes mellitus, hypertension, and coronary or cerebrovascular disease portend a poor prognosis, as has been discussed. And one part of the COVID-19 has been a mimic of STEMI, where we have seen that ST elevation mimics along with increased cardiomyopathies like troponin and ECG and echo abnormalities were seen, which was fairly unrecognized in the early part of the pandemic. And most of them, when they were subjected for intervention, they turned out to be normal coronaries. So a possibility of direct myocardial injury in the form of myocarditis was suspected. And even in our center, we have seen such mimics of STEMI. And since it was unrecognized in the early part of the pandemic, many of our colleagues got exposed to COVID-19 and They were quarantined, most of them. Thankfully, none of them had any fatal injuries or morbidity. And these STEMIs, we have seen that there has been significant reduction of more than 40% in all cardiac centers across the world, as has been reported from Italy, also in the Indian subcontinent, and even in China it was reported, and even reported by the cardiac organization in the United States of America. So one of the reasons could be their patients have been too anxious to visit hospitals, maybe for the fear of contracting ACS. And most of them presented late to the ERs of respective centers. Most of them just warded off their symptoms at home, presenting late to the institution. Even in our center, we have seen that late presentation of STEMI, presenting with acute severe myocardial regurgitations, ventricular septal ruptures, cardiogenic shock, and sometimes even in pericardial effusion because of the cardiac rupture are commonly seen. And even as I speak, we are seeing these cases every day. And as has been discussed, these people develop aggravated CAT or delayed complications of STEMI. And there were various theories proposed in the initial part of the pandemic. Some of them, like there are reduced daily stresses and reduced pollution because of the lockdown imposed. But however, no concrete evidence were given for this. And if at all, if there is reduction of daily stresses, then it is worth of the attention of policymakers, governments and healthcare providers to implement these preventive measures to have a robust preventive care for STEMI cases and related morbidity and mortality.
Thank you very much indeed.
It may be my ignorance of these matters, but it seems that COVID on occasion could be a multi-system disease, cardiovascular system, central nervous system, renal failure. That's had quite a lot of interest recently, even skin rashes. And later on in the patients in intensive care unit, high antibody levels were a marker of a poor prognosis. And to me, this all sort of shouts immune complex deposition. Has there been any work done on this?
I mean, certainly inflammatory responses, serious inflammatory response, cytokine storm, evidence of that is very clear. But
yes, I agree. In fact, in your excellent introduction, Donald, you have almost covered all the important points about COVID-19 and cardiovascular disease. And I also enjoyed Dr. Kulkarni's presentation because, again, he covered most of the important points relevant to a cardiologist, such as, you know, the decrease in the number of AMI cases presenting to casualty, as well as to the CCU, and also, you know, cardiologists being caught really unaware that the patient has got COVID-19 and maybe, you know, got infected, especially if the patient is in the cath lab and all that. And the other problem, of course, is if you suspect the patient has got AMI, you don't wait for the results of that test. You get the patient in the cath lab straight away, which again increases the risk of the personnel. What else? Yes, and going back to Donald's presentation about the multiple causes of myocardial injury, including thrombosis, including perhaps hypoxia is another mechanism. And perhaps that explains why, you know, you can have, and also sort of destabilization of the atherosclerotic plaques. And so that explains perhaps why you don't need, you know, a patient with very severely blocked, narrowed coronary arteries in order to have an AMI. And in fact, I read that there are people who felt that perhaps these patients, instead of having an invasive coronary angiogram, perhaps they should have less invasive, non-invasive CT coronary angiogram as a first investigation, which would make the hospital personnel less at risk.
So just Philip, to respond further to your question, as you say, all these organs being affected smacks of immune complex or some sort of other immunological response. But the other ways in which you can get that are, for example, in DIC, because of the coagulation and multi-small vessel activation throughout the body, damage throughout the body. Secondly, this inflammatory cytokine storm that damages kidneys, liver, lung, brain, and so on. It's a general host response to attack rather than necessarily a specific immunological response. But thirdly, what's interesting, as you mentioned kidneys and brain, and certainly the ACE2 target is present in large amounts in heart, in lungs, in the kidneys, in the Leydig cells of the testis, but also brain cells, a lot of interest in neuropsychiatry and what's happening. So that's basically a multiply disseminated target protein, which may explain why some of the organs are being attacked more than you might otherwise expect. Coming to this stage, I'll ask Dr. Rajesh Kamath to say something about the indirect effects he's seeing in India.
The prevalence of diabetes and hypertension is slightly on the higher side among Indians. So about 1 in 10 Indian adults suffer from some form of diabetes, some level of diabetes, some intensity of diabetes, and 1 in 4 Indian adults have some grade of hypertension. Therefore, Indians are naturally predisposed. When we look at figures like 1.38 billion, 1,380 million people, 10% and 25% of adults adds up to huge numbers. Secondly, from the socioeconomic point of view, looking at access to care, affordability of care, we see that India has 100 million migrant workers. The average family size in India is about 5. So if you are talking about 100 million interstate migrant workers, you have workers from the poorer states going to the wealthier states. And if you look at interstate GDP per capita, there are huge interstate variations in India. So you have a state like Bihar with a per capita GDP of $600, and then you have a state like Goa where it is 12 times more. When we say India, there are huge interstate variations. You have people from the less wealthier parts of the Indian geography moving to the parts where there is more employment. So you have 100 million people like that, and each family has about 5 members. So we are talking about 500 million people who are dependent on irregular, non-formal employment. When India went in for the lockdown, approximately 400 to 500 million people were thrown under the bus. Access to healthcare, one of the most important things that determines access to good healthcare in India is incomes. Vast parts of India, about half of India, have terrible public healthcare infrastructure. About half the Indian population really doesn't have access to good healthcare infrastructure, which is the reason that they would need to spend out of pocket to see a private care physician. With the lockdown, what happened was you already had a weak public healthcare infrastructure. People were poor overnight. In addition to that, they lost jobs. People have a predisposition to suffering more from COVID-19 because of diabetes and hypertension. And plus you cut off their incomes, and people were not able to access healthcare because public transport was also cut. A lot of people in India, probably about half of the population, accesses their healthcare through public transport. So with public transport being sealed off overnight, and this happened for about 2 months, preliminary estimates from some studies suggest that we might see 40 to 50,000 extra deaths over the next 2 years just from TB. How many from heart disease? We don't have any evidence as of now, but the numbers will not be insubstantial. So these double or triple whammies of a poor healthcare infrastructure, loss of jobs, susceptibility to COVID-19, all of these add up to a potent and toxic cocktail.
Thank you very much indeed. Could you say something about how things are funded? If you wanted to find out if somebody has the infection using either a genetic test or antibody test, is this purely private? Is there provision for public health funding for at least some patients to be able to be tested?
Yes, sir, very much. What is happening right now is that anybody who has symptoms can approach a government health facility and get tested for almost free. Someone who doesn't have symptoms probably will have to pay for the test. Testing is also being ramped up massively. The key point that I will want to make is that we would need to ramp up testing. Experts say that a country can say that it has reached an adequate level of testing when we reach a test positivity rate of 5%. But the government has ramped up its strategy to test it. It is testing all contacts, and pretty much anyone who wants to get tested can get tested.
Thank you, Donald. I enjoyed all the presentations very much. Well, two questions now from the previous speaker. Were you saying that there is an increased risk of septal rupture and free wall rupture with the cases you've seen?
Per se, not because of COVID-19, it's because of the patient not seeking medical attention because because of fear of contracting the virus. So their presentation to the ER being very late, maybe some after 48 hours, 72 hours after they have suffered an MI. So that is this, because of the delayed presentations, we are seeing more of complicated MIs, which we would have normally not seen if there wasn't an COVID-19 pandemic.
Yeah, I was wondering about that because when I was a young, struggling cardiac surgeon, we used to see an awful lot of septal ruptures, but with the advent of early angioplasty and stenting, following STEMIs and so on, when I was an older but still struggling cardiac surgeon, we saw very few of those. So that explanation sounds quite reasonable. And incidentally, I have a strong affinity to Hyderabad. I've been there several times to various institutes and so on. So thank you for that. Dr. Kamath, in the UK, we talk about being Black or South Asian origin is an important independent risk factor for COVID-19 deaths. So do you think, apart from a high prevalence of comorbidities like hypertension, diabetes, and so on, is there another factor, a genetic factor or any other factor that you can throw some light on?
Yes, sir. Sir, being from India, the most important differentiating factor in India is income and the social strata from which you come. Genetically, I haven't seen any evidence as such. So in India, it is, pretty much the whole game is based on income. So if someone can afford good care, their chances of survival go up dramatically. If someone can't, especially from the states which are impoverished, where about half of India lives, so that is one differentiating factor, the income of the family. The second factor is whether the person is in a rural area or in an urban area. So perhaps 80 to 90% of Indian specialists practice in 35% of India. So the rural-urban distribution in India is 65 and 35. 65 rural and rest in urban. But the distribution of specialists is the opposite, perhaps in a Versa ratio, 85 to 15. So therefore, someone in a rural area has got much lower chances of survival than someone from an urban area if they contract the virus, if they contract the infection, and if it goes on to create a serious illness.
Thank you. Thank you very much.
That's very helpful. Thank you. I think what's missing, looking at the literature, there's a lot of observational and anecdotal comment. What's missing is adjusting for multiple risk factors, adjusting for socioeconomic class, adjusting for, as you say, provision of healthcare. And I think we need to know a lot more about that before we can be sure about what the mechanisms might be. But nonetheless, if 1 in 3 coming to intensive care unit, that's to say 3 times expected, is what's happening. That really needs to be looked at very seriously, and especially if we're talking about a second wave. And if you look back to the first SARS, a third wave, we need to be really well informed as to what we might be doing to protect these people. Our last contributor from the journal, we now have as our final contributor Dr. Emmanuel Nsutebu from United Arab Emirates. You had a very interesting editorial on how to treat, what about anti-infective agents, but also what about the risks and benefits of treatments. We've been talking today about cardiovascular risk, patients with background cardiovascular disease being more likely to do less well. In your own centre, what you're doing when patients come in with cardiovascular disease, diabetes may be more common, do you manage them differently?
Thank you, and thank you for inviting me to speak. As you're right, the paper which we published, it was an editorial about the use of specific antimicrobials in COVID-19 and the dilemma which I think we all recognize as clinicians about whether to treat now or wait for evidence. As you said, patients with cardiovascular disease are at much higher risk of complications and mortality of 10%, as opposed to 1 to 3% for the general population. So there's clearly, from a clinical point of view, pressure to consider doing something for these patients because of the high risk of complications and mortality. But against that is the risk of toxicity, with high risk of arrhythmias and also high risk of other side effects such as shock with some of the drugs. So with cardiovascular disease, the risk is using antimicrobials such as hydroxychloroquine and macrolides, if you believe the data with macrolides, and causing more harm than good. So what we argue in the paper we should publish is that really all efforts should be geared around using developing trials to answer these questions. There have been too many observational studies, or in my opinion, too many observational studies that have resulted in a lot of conflicting results, despite using a lot of these drugs in a non-preclinical trial setting. With respect to your specific question of whether to use what we do, we manage patients with cardiovascular disease very similar to other patients, mainly good supportive care in our center. Our sites and Abu Dhabi, United Arab Emirates were very pro hydroxychloroquine, and it's still in the national guidelines as we speak. Mm-hmm. However, a lot of the clinicians now, based on the well-controlled, well-designed and large trials like the recovery trial from the UK and also the WHO Solidarity trial, are very reluctant to use hydroxychloroquine because of futility, lack of benefit shown from the well-designed, well-run recovery trial and also the WHO Solidarity trial, where the hydroxychloroquine arm was suspended because of futility. So despite being in national guidelines, there's still a lot of local reluctance by clinicians to use it because of these trials that have shown lack of benefit. And that also applies for drugs such as Kaletra, which is an antiviral used for HIV, and also in the recovery trial showed no benefit, and that arm also was stopped. What we do is you were using steroids more, because of, again, based on the recovery trial showing 30% reduction in mortality in patients who were ventilated, and 20% reduction in mortality in patients who were on oxygen. So patients with cardiovascular disease would avoid using hydroxychloroquine. If we were to use an anti-infective agent for atypical pneumonia, for example, we would avoid azithromycin because of higher risk of QTc prolongation and arrhythmias, and use antibiotics such as doxycycline instead. and then use dexamethasone for patients who are requiring oxygen. We would monitor them closely, and patients who have a history of cardiovascular disease what our practice is to get a cardiology consult early, and so they're seen by a cardiologist. I know there's not yet any evidence from any studies that made a difference in terms of outcomes, but because of the high risk of cardiovascular complications in patients who already have a heart disease, that's what we're doing in our site.
Thank you very much indeed.
Like actually to reiterate what Dr. Rajesh had said, that it's the core or the root core of the problem during the pandemic is actually the underfunded public health service. And it's the time nowadays to shift health services at a global scale from a medical approach to more preventive and public health approach. And we could see the evidence in Japan, where they moved quickly and swiftly out of the COVID pandemic because of the 5-star public health centers scattered around Japan. We need an effort to make evidence-based measure to make people at high risk avoid actually being getting into the treatment cycle.
In the European Union, they have a regular annual meeting of all the public health leaders for all 28 countries, well, it was 28, it's now 27, to discuss serious emergencies. And despite that, they were not able to help Italy with having enough equipment, preventive and specific, and staff to be able to help, even at that stage. The USA, President George W. Bush, he wanted to have $7 billion for Congress to promote public health, to do this kind of thing. His proposal was not supported. For the future, there is a further discussion in all the right health policy centers to say what could or should be being done. People have a very short-term memory when it comes to these diseases, but a very important practical point. We have a question now from Ron, and his question is knowing about inflammatory and coagulation pathways, what about aspirin or the novel oral anticoagulants, or both, as a prophylaxis for high-risk patients? Bernard, do you have any comments on say, on the prophylaxis for coagulation or aspirin or both?
In coagulation, anticoagulation is certainly advocated in patients who are sort of at the iller end of the spectrum, patients who are less mobile, patients on ICU and so on, especially if the patient is of European descent. So yes, I mean, I think anticoagulation probably with heparin in hospitals is already practiced. Now, the suggestion of aspirin is a very, very, very interesting one. I mean, I'm not aware of any trials of aspirin versus placebo in COVID-19, but I think it's a very interesting thought. I mean, given that aspirin reduces cardiovascular diseases, including AMI and stroke, which are, of course, a major cause of morbidity and mortality of COVID-19, then I think the use of aspirin may be a very easy, cheap, and safe, or perhaps even life-saving idea. I think that's a very interesting idea that ought to be explored further.
I think it also touches on Dr. Nsutebu's point about the need for formal trials. And it's interesting, for example, the European Medicines Agency now has a watching brief on non-steroidals, because there were some anecdotal reports from France about people on these agents empirically doing worse. That may just be they were on them because they were worse. Do we have any further comments or questions? We shall conclude the session with some slides bringing together some of the key points we've heard about today. This helpful chart comes from a paper by Drigan and colleagues, published recently in the Journal of the American College of Cardiology. And it breaks down patients either with or without COVID-19 and with or without prior cardiovascular disease. For those who have got no prior disease, everyone is at risk with the COVID-19 of getting one of these potentially very serious or fatal syndromes. So you have to be very alert and to monitor, and as we heard from one of our contributors, to consider whether markers of cardiac ischemia are really due to vascular problems or due to some other indirect evidence of what could still be serious damage. And then for patients with prior disease who don't have the condition as far as we know, and that's important because not many people are being tested still, it's really important that we consider, as we heard from Southampton, we should be using telemedicine, we should be using self-monitoring, we should make sure these people do not stop their medicines or get lost to follow-up, and it's possible to make sure that their risk factors are recognized and managed as well as possible. And as we heard from UAR, from Dr. Nsutebu and others, we should be being very careful. If we know patients with cardiovascular disease, we know they've got up to 5 times chance of mortality, we should be very careful to monitor these people, to look for early warning. We know from the recovery trial published recently in the New England Journal of Medicine of benefits in the more severely ill patients from treatment with dexamethasone. But that again has got its own complications. So I think we should be having a very clear guideline-based approach to how we should manage our patients. In terms of where you might look, every organization around the world has been trying to get good guidelines. The European Society has got some very good guidelines on its website if you haven't seen them, last updated a month ago. And for example, for hypertension, they've got this clear advice what to do, medication. There were some concerns about blocking the renal system. Well, they say keep going with the treatment, but certainly monitor the patients, look at video consultation. And then in hospital, again, there's clear advice about what to do and thinking about kidney injury and to be aware of risk in these patients. Because renal damage, because of the protein on the kidneys is commoner, it's important patients are on the potassium sparing treatments for blood pressure, which are more common in the more severe hypertension, to be aware to monitor potassium and so on. And then the next slide is far too detailed, but it gives you a breakdown of what to do in the ER with patients. Here you need to look at the guidelines, but it talks about what about somebody who's got cardiovascular problems, what do you do? And you should be triaging red for emergency. You should manage anyway, being careful with your personnel, urgent a few days, lower priority, elective. And it talks about heart disease, valvular disease, heart failure, arrhythmias and so on. A very good way to consider how you should rationally look after your patients as well as possible. I should like to close now by thanking my co-organizer, Professor Bernard Cheung, who is trustee of the charity and editor of the Postgraduate Medical Journal. In the slide, you can see a list of forthcoming monthly free webinars from our Healthy Heart charity, the Cardiovascular Research Trust. To find out more and how to register, go to our website healthyheartcharity.org.